So thank you. I'm Malou Heijligers. I'm a clinical geneticist in Maastricht. I work mostly with couples having a wish to become pregnant or who are already pregnant and who have ultrasound abnormalities. But today I want to introduce you briefly into the world of PGT, pre-implantation genetic testing. So first, as I said, a pre-implantation genetic testing is a medical term for PGT, also known as embryo selection. And embryo selection is offered to couples who have a high risk of having a child with a severe genetic disorder. High risk for us is a risk of either 50% chance of 1 in 2 or 25% chance of having a child with a genetic disorder. We offer it in Maastricht as the only center in the Netherlands, so most of the information I'm going to give you is compatible for several PGT centers worldwide. The most common disorders for which PGT is offered is mostly hereditary breast and ovarian cancer, various muscular diseases like myotonic dystrophy and spinal muscular atrophy, Huntington's disease, cystic fibrosis, fragile X syndrome. But inherited cardiac diseases we are going to discuss tonight is not a common group of disorders we are offering PGT for, and therefore we feel that's important to introduce it to you and to get you to know with PGT what is PGT and why do we offer it to couples who have an LMNA mutation. So what is needed for PGT? Firstly, we can only offer PGT when there is a genetic diagnosis. So you have to know what mutation is running through the family. Then, if we know the mutation, the PGT laboratory needs blood samples of the couple who wants to get pregnant, but sometimes also from the family members. So in case of an autosomal dominant disorder, so when a disorder is running through the family, then we need the blood of both the couple, and most laboratories will also need the blood of the parents of the affected member of the part of the couple. So when the female is affected with the mutation, we also need the blood of her parents. When the husband is affected with the mutation, then we need the blood of his parents. There will be some PGT centers who use blood of both parents as well, or if there is an affected child available, we will use the blood of the affected child. In the Netherlands, the estimated preparation time of a genetic test for embryos is about 6 months, but that can change between the laboratories. There will be laboratories which will take up to a year. There might also be laboratories that will be faster. Most important is to know that we cannot use the genetic test which is performed in the blood, because if we have an embryo and we're going to test an embryo, we just have a small part of DNA available to test. And a blood test is just not suitable because it won't, we will never be sure that the embryo is not affected. So with using the blood of all the family members, we are going to prepare a very safe genetic test suitable for testing the embryos. But then, of course, we also have to get embryos. How do we get embryos necessary for PGT? For that, we use IVF, in vitro fertilization. For IVF, we use hormones. So the woman has to inject hormones herself in order to get oocytes, so to get eggs, more than one egg, to grow in the woman. If we have several eggs, the gynecologist is going to make ultrasounds to see how many eggs are available and how big they are. After taking ultrasounds for a while, so a couple of days after each other, we are going to get the oocytes out of the body of the woman, so out of the ovaries. They do that with an ultrasound to see where are the eggs, how many are there, and then they take them out of the body. And then we fertilize the eggs in the laboratory with the semen, which you can see on this picture as well. After the fertilization, we let the embryos grow until they are 5 days old, and then the embryos are big enough to take a sample of them. So we actually suck part of the embryo, a biopsy, that's a medical term for it, and we biopsy the embryo. By taking a small part of the embryo, we can test the actual DNA of the embryo itself. And then we use the genetic test we've already prepared in the genetic lab to test which embryo is affected with the LMNA mutation and which one isn't. The embryo on itself will be put in the freezer. So we are only going to test the biopsy, so the part we took away from the embryo, that is tested for the genetic mutation, and the embryo on itself is freezed, so it won't grow any further. In most laboratories, doing a test on the biopsy of the embryo will take a couple of weeks, and then the couple gets the result of the embryos that are tested. So when a couple has several embryos, for instance, when a couple has 4 embryos, you will get a result of all the 4 embryos. So you know whether embryo 1 is affected or not, 2 is affected or not, 3 is affected or not, and 4 is affected or not. In most countries, only 1 embryo will be transferred in the uterus because we want to avoid a pregnancy of twins or triplets. If people get pregnant after PGT, then it is important to know that PGT is a very safe procedure, very safe treatment, but it has a misdiagnosis risk of about 1 to 2%. That means that after being pregnant, when being pregnant after PGT, there's a 1 to 2% chance that the baby does have the LMNA mutation. And for that reason, we always advise people to do DNA testing even after PGT treatment. Depending on the country you live in, there are several options. So we always discuss with the couples that there is an option to do prenatal testing. So to test during pregnancy with a chorionic villus sampling or amniocentesis. But you can also choose to test after birth of the baby, doing DNA testing either on the cord blood or later in life to be sure that the baby actually doesn't have the misdiagnosis, a chance of 1 to 2%. And this is in a nutshell the PGT procedure, and I'm happy to answer questions at the end of all the presentations of my colleagues.
Thank you very much, Dr. Heijligers. As Malou already said, you can put your questions in the Q&A. And thank you for this nice overview with also perfect illustrations to show what's actually happening during a PGT. I think we will continue with Job. Dr. Van Donschot, the floor is yours.
Yes, I had to unmute myself. Yeah, so actually we now had a really nice introduction into what PGT is. And as Dr. Heijligers already introduced, inherited cardiac diseases are not that common as an indication for embryo selection. And now I will just have a couple of slides to illustrate why that is. So why is inherited cardiac diseases so difficult for embryo selection? So I think everyone knows already a lot about genetics, also from previous webinars, so the genetic background of LMNA and how that works. And with this presentation, I want to challenge that a little bit. And that has to do because we often assume that the genetic background of cardiomyopathies is very simple. And what I mean with that is that when we turn it into a graph, let me see, do I have a pointer here? No. But on the left, the vertical axis, we display the genetic risk. And if we would say you need to reach a certain threshold of genetic risk in order to develop the disease. If you would say like it's simple, then it would look like this, where if you have the LMNA mutation, it will be enough to reach the threshold, and that explains why the patient has a cardiomyopathy. But that would also mean that if a family member gets tested for the mutation and the mutation is present, then we would assume that that family member will also develop the disease because the LMNA mutation will be sufficient to reach the threshold. And also otherwise, if a family member doesn't have the mutation, that there is no risk of developing disease at all. So this is what we often assume when we think about the genetic background of cardiomyopathies. But how it is in reality is often that the genetic mutation, so the LMNA mutation, will not reach the threshold on its own. And that's what we often see in families of LMNA patients, is that some family members might have the same LMNA mutation and don't develop the disease at all. And this is what it is in reality. And that's something that we call incomplete penetrance. So incomplete penetrance is more or less that just having the mutation is not sufficient to reach the disease threshold. So that leads to a lot of questions, like probably in the patient, there are other genetic factors that play a role that determine why the patient developed a cardiomyopathy. But for the family member, probably there need to be other factors in order to develop the disease when the LMNA mutation is present. And if family members are tested and they don't have the LMNA mutation, the question is there still a risk for this family member, yes or no? And there are some very recent research being done on this topic, and this is just a paper of a couple of weeks ago. And in this very nice paper, they investigated intermediate effect variants. And this is specifically in this study for hypertrophic cardiomyopathy, but this is relevant for all cardiomyopathies there are. And intermediate effect variants are so genetic mutations that we have, but an intermediate effect variant will never be sufficient to develop disease on itself, but it will contribute to the genetic risk in total. And probably these intermediate variants, when you get genetically tested, they are also tested, but we just didn't recognize them yet. So probably they are not reported, these intermediate effect variants, or they are reported, but they are set as being a very causal strong mutation, while probably on its own, it will not explain the complete disease. So with this new knowledge, and this is very recent, it is from a couple of weeks ago, so this will change probably how we look at genetics for cardiomyopathies in the coming years. So if we add the intermediate variants to the puzzle, then probably it will contribute on top of the LMNA mutation towards the disease threshold to eventually develop the disease. But still, as you can see here, the threshold is still not reached. And that's also of some very recent research looking into polygenic risk scores. And these are two very big studies published last year in Nature, specifically for dilated cardiomyopathy. And polygenic risk scores, something went greatly wrong here. But what it is, a polygenic risk score is a combination of a lot of hundreds of thousands different genetic mutations that together explain a very small risk. I don't know what went wrong at this point, but the main message is this is purely research. It is not part of diagnostics yet, but this will become reality in, I think, between 5 and 10 years from now. And if we add the polygenic risk score to this hypothesis, then probably it's the combination of the complete genetic background of a patient that in the end will explain if someone will develop the disease or not. So at the moment, we're only looking at this LMNA mutation, yes or no, which is very, very simple, especially when you see a graph like this, where there's a complete genetic background of polymorphisms, polygenetic risk, intermediate variants, and it's the combination of all of that that will explain in the end if someone will develop the disease or not. And this is purely hypothetical. It's a very active field of research, and I think it will be very important in the future for family and to communication to see who's high risk in family and who's not. So why is it important to explain this? Because this is also exactly the challenge currently in embryo selection. As Dr. Heijligers already said, like if we do PGT, so embryo selection, we can only do it for the one variant. So in this case, it would be the LMNA mutation. If someone with an LMNA mutation comes for embryo selection, what we can do, we can select embryos if they have this black bar, yes or no. So we take away that risk of that one variant. But of course, as you can see here, we have to be sure if we take away that black bar, so the genetic risk of an LMNA mutation, that the residual risk, so the genetic risk that remains after that, is very low, because otherwise we do a procedure, do embryo selection, and in the end there will still be a risk to develop the disease. On the other hand, it also needs to be a significant risk reduction. So it has to be the black bar, so the LMNA mutation, what we remove, it has to be a strong genetic risk, because otherwise couples will go for a very elaborate PGT procedure, but in the end it maybe wasn't even necessary because the genetic risk was very low to start with. And as an example, I always use this case. So this is a patient, a young man, or a man who is now has a wish for children, but he developed a dilated cardiomyopathy at the age of 12. And he had a heart transplantation at the age of 15, and genetic testing revealed a titin mutation. This is a very extreme presentation for someone with a titin mutation, because overall titin mutations are thought to be very mild, with a very late adult onset of the disease. And also, if you look in the family, then his mother had also had a titin mutation. She never developed any sign of cardiomyopathies. And the father of the mother also had the titin mutation, also didn't develop any signs of a phenotype. If we turn this into the graph that I just presented, then probably in this patient, there is also a lot of other factors that play a role, a lot of other genetic factors that play a role why the disease was at such a young age of onset and why it was so severe. So if we would then do PGT only for the titin variant, probably there is still a high residual risk, so a high risk for the embryo in the end to still develop the disease. So, and that's a bit the challenge for the complex background of cardiomyopathies and embryo selection. In the ideal situation, it would look like this. So then we could really do accurate risk prediction for embryo selection. We could test the embryos for all the variants, and in the end, you get a percentage of risk of disease development. And then it would be easy, of course, because in this case, we would select embryo 4 because it has very low risk for disease development. But this is still an area for the future. I really believe it will go this way, but we're not there yet. We can only test the black bar, so mutation present, yes or no. So we don't have this accurate quantitative genetic risk prediction yet. So how do we do this in current practice then? And that's something we published last year. So we developed a clinical risk prediction model where we use clinical factors in the patient and in the family as a surrogate for the genetic risk, the intermediate variants, and the polygenic risk. And this is something that my colleague, Dr. Vase, will explain in the next presentation a bit further. Because some key points of this presentation, it is always it can be quite complex, and that's also what it is. But at this moment, we see still genetics and diagnostics in clinical practice as a very simple derivative of something complex, where we say mutation is present, yes or no. We are, at the moment, we're in the middle of unraveling the other genetic factors that play a role for disease development in cardiomyopathies. And pre-implantation genetic testing, I told how complex it is for cardiac disease, but it is available and it still helps a lot of couples. And it's really a prime example for couples making one of the most important decisions in their life, to help them to make, to give them possibilities that otherwise wouldn't be there. And maybe in the worst case scenario, people will not get children purely because they're afraid that the disease will go on in the disease. And this is a perfect example how this can help this important decision making. But however, at the moment, there's a very tailored approach for every couple. So for every couple and its family, it has to be, we have to look about how is the disease presentation in the family, what genetic factors are present, how does the mutation runs in the family, to make a decision if PGT is the right choice for this specific couple. And There are not really specific guidelines for it. PGT is already available for almost over 30 years, but still for cardiac disease it's quite relatively new. And at the moment we're working with an expert group with a lot of different associations to come up with some consensus about where should we draw the line for PGT embryo selection for cardiac diseases, which genes are high risk, which genes are low risk, to assist every cardiologist and geneticist in counseling patients and helping them to make the right decision. So I will leave it now for that, and then my colleague Dr. Vase will proceed with the next presentation.
Perfect, thank you, Dr. Van Donschot. Very clear presentation and a lot of info. So if this is still fresh information in your mind, please ask your questions in the Q&A. We will ask the questions later on to our expert panel. And then indeed, Dr. Vase.
Yes, thank you. So thank you all for joining. I will share my presentation. Yes. So my name is Isa Vase. I'm a clinical researcher within the cardiogenetics field at Maastricht University. And as the last part of this presentation, I will talk to you about previous, current, and future research within the field of PGT and cardiogenetics. As already mentioned before, cardiogenetics is a relatively new field within the field of PGT. We've been now been doing that for the last 2 decades approximately. And we believe that this article is a very important article. It was published in 2021 by one of our colleagues.
Dr. Vase, I have to interrupt you for a second because I heard you pressing for the next slide, but we still see the first slide.
Okay, wait. I will stop sharing and I'll try again. Thank you.
We are completely up to date with what you say is also on the screen.
Let's see.
It was not in presenter mode before.
Is it now?
It is. Thank you.
Yeah. Okay. So this was an article that is actually published by one of our colleagues in Sydney, and they looked at the decision-making process and the experiences of preimplantation genetic diagnosis in inherited heart disease. This was a qualitative study, so they actually did interviews, and the goal of this study was to actually look at how are PGT decisions made and to help other families that are considering this option. So what they did is they included 20 participants, 15 with inherited cardiomyopathies. So that could be dilated cardiomyopathies, could also be hypertrophic cardiomyopathies, and 3 participants with inherited arrhythmias and 2 partners. So in total, those were 18 families, and 7 of those decided to actually go for PGT. So PGD is actually an old term for PGT, so it means the same. And 9 decided not to go for PGD, and 2 started with it, but eventually didn't complete it. And what they saw in this study is that couples that were actually considering PGT had 3 subtexts that they found the most important. One of this was past experience of the disease. So, for example, sudden cardiac death that ran in the family, or sport restrictions, or a clinical heterogeneity. And the concept of clinical heterogeneity actually means that some patients express the disease very severely and have severe complaints, while there are other patients with the variant that actually don't have any symptoms. Then what other people found very important was intergenerational responsibility. So they looked at what was important in previous and next generations, and at practical considerations, so things like finances and age. And what we saw is that people imagine their future, and if they are able to integrate the variant within their imagined future, they would actually decline PGT. But if they were not, so if they saw it as a threat to their imagined future, they would often decide to undertake PGT. So what I did in the next slide is I put down several quotes that were used in this article to show you that everyone looks at it differently. So on the left-hand side, those were all couples that decided to go for PGT. And on the right-hand side, those were couples that decided to decline PGT. So I divided them into the different subcategories that people found important. So I will guide you through it and I'll read through it with you because I do think this is very important. So for example, the first male, he said, but probably the key reason I'm not declining PGT is you still have the risk that you destroy the risk with PGT of sudden death, destroys the risk that your kid goes to school one day and doesn't come home. So that was the main reason for this couple to undertake PGT. While someone else actually said the chance of an inherited heart disease just wasn't a massive burden. And so we just also felt that we were going to be okay. I guess the risk benefit analysis just simply wasn't it. It just wasn't there in the end. So they both considered the same factors, but in a very different way. Then I also just mentioned that sport, for example, could be a very important factor. So someone said sport was a massive part of my life and probably one of my greatest passions. It took a long period of adjustment, almost like a grieving process. So this person decided to go for PGT, while someone else said, you know, our child is likely to have a very normal life and obviously some limitations for them. But yeah, I think we just felt comfortable knowing that what we know of the people who live with it in our family. Someone else said, you can do all the clinical screening in the world, the uncertainty of the clinical pathway of a child with the gene, not knowing whether they would express it or not. So I just couldn't face a lifetime of that. Another person said, because I've got the thing, my daughter's got it, and we know how to manage. It's not likely to present quality of life issues or any major learning disability or something else that could have a traumatic impact on our entire life. So that is someone who declined PGT. In the last two quotes, I didn't want to experience that myself, sudden cardiac death of a child, but also then her children and her children's children, and that would have just continued. If I had decided to go through PGT, then that would stop all the other generations from having to make that decision and spare them the difficulty. So that was about the concept of intergenerationality. And another person said, I thought, gosh, if my mom had to make that decision, I wouldn't be here. And I think I'm contributing to society at some or on some level. So what I would really like to show with this is that whatever decision you make regarding PGT, that is totally okay, and that everyone has their own reason for it. So one of the most important things that was discussed in this article is how we should go through this process. So we just really think that it's very important to discuss different reproductive options early, because then patients have the time to deliberate. They have the time to really see what fits for them and what they would prefer. We think it's important to explore past experience of the disease, because it's very important to normalize that your past experiences have impact on the decision that you're making. We have to manage the expectations of the PGT process because it is a very time-consuming process. It is, some people called it even all-consuming, because you're continuously dealing with insecurities. It has a very day-to-day impact. It can take quite a lot of time, and sometimes it has a low success rate. So that are several factors that you also have to take into account. And we have to realize that it's a very personal decision for a patient and a couple. And it's very important as healthcare providers that we support and respect that final decision for people. So we just think that that was a very important article, and I will come back to that article just in a little bit. This is something that Dr. Verdonschot already introduced. This is an article that he actually wrote, and it helps guide clinicians in deciding which patients will benefit the greatest risk reduction from PGT. Because, as already mentioned before, it's very difficult to say which couples will actually benefit greatly from it, and that is very important. So the first step is actually to look at whether someone possesses a well-known high-risk severity gene. Because if someone possesses one of these genes, you don't have to go to step 2, in which we actually determine what kind of phenotype someone has, or the family history of the patient. So LMNA is actually one of the variants that we see in step 1 that we would now actually advise to approve for PGT if someone prefers that, if it is feasible. So I'll go to the next slide. So in the Netherlands, LMNA variants were actually a no unless indication for PGT. So we always had to go to a working group to really decide together whether or not a couple could undergo a PGT trajectory. But we personally believe that it is a well-known risk gene with quite a high penetrance, and we often see heart transplantations, for example, ICD implantations, and it's a disease, it's a variant that could cause sudden cardiac death. So that is why we decided that it had to go into the yes category for PGT, which was approved in the Netherlands. So it's a yes as long as category now. So the current research that we're doing, we see over the last years that the requests for PGT for cardiogenetic disease have been rising, and a lot more people now know about the option, and we find it very important that people know about the option. So we expect that there will be an increase in PGT requests. And what becomes more and more important is the patient perspective, the considerations that patients have. Why would they want to perform a PGT trajectory, and why would they prefer not to? So our goal really is to improve the counseling to make it more patient-centered. So we have now actually developed a questionnaire study that was based on the first study I told you about. And now we want to look at the high-risk genes. So look at LMNA and look at it on a much larger scale, because they performed it, they did the interview studies with a relatively small group, and we would now actually want to do it on a much larger scale to really see how can we improve the counseling and make it better for everyone. So we would really love it if you could help us with that. So we decided, we made a questionnaire study, and we based it really on the outcomes of that previous study that I showed you. So the questionnaire would be completely anonymous, and we would ask you questions about medical and family history, obstetric history, and the most important thing is the considerations surrounding the PGT trajectory. We want to see what you find important. So there will also be some questions, some statements about PGT, if you agree with them or if you disagree with them, which is also fine, or if you're neutral. And I think that one thing that is important to mention is that it are all hypothetical situations. So we're not really offering a PGT trajectory in this questionnaire. We simply just want to know what you think about it. So if you're really interested in PGT, that is something that you're going to have to discuss with your GP and then ask a transferal to the genetics department. So what we will do is we will send you a mail probably somewhere next week that will have a detailed explanation about what PGT is. There will also be a link to this to an introduction video about PGT. So that will be the situation in the Netherlands. And there will also be a link to this webinar from today. There will also be a detailed explanation about the study that you can really just read through and see if you understand it. If there are any questions, you can always contact us. The only inclusion criteria is that you're a carrier of the LMNA variant. And as I already said, it's very much opinion-based. There's nothing is wrong, nothing is right. And you can skip questions if you feel uncomfortable answering them. And it will take you about 15 minutes to answer this questionnaire. So that is a research that we are doing right now. In the future, we want to do way more research because we think this is a very important field. So we really want to determine which couples will benefit the greatest risk reduction from PGT. So we really want to dive into the different variants and see what we can still do there, and also look at the polygenic risk score, for example, as Dr. Van Onschot mentioned. And we also want to look at, for example, what the influence of the IVF trajectory is on female carriers of a variant. So there's still a lot more to discover, and we could always use your help with research. So thank you.
Well, just wow. Thank you, Dr. Vase. It's great to see three different. I have it there. Yeah. So what I think it's great to hear three perspectives on PGT. I really enjoyed that because it's also the patient perspective in their real life examples that you mentioned. It's I think that was very nice. I know there are questions that I got personally actually over the last few years, and that was one of the reasons why we also embrace the fact that the three of you asked to tell the patients about PGT, because it's such an important topic. So I have questions myself, but I already see that there are some questions in the Q&A. So let me start with those. One question is, where would you advise people to start if interested in PGT? And that means in Europe and outside Europe. Who can answer that question? You stated GP, Dr. Vase, but perhaps you can elaborate a bit on that.
Yeah, I think that if you're interested in PGT, you could also always start with going to your GP and discussing it there. But I think it is also always nice to ask for a transferal to the clinical genetics department, because I think the clinical genetics department has way more experience in it, and they can counsel you better and see what it is that you want specific information on, and they can really guide you from there. But I do think you need a transferal from the GP, if I'm right. But I think Dr. Heijligers could answer that better.
Yeah, it actually will depend on the country you're living in. In some countries, you can go to private clinics as well who offer PGT. So then you can go to them without a transfer of your GP. In the Netherlands, yes, indeed, you need to go to the GP and then get a referral to either Maastricht or one of our transport clinics. But there are several countries, especially in the USA and also in Europe, that have private clinics who offer PGT.
Perfect, thank you. I see Dr. Van Onschot would like to add something there.
Yeah, I think Malou also talked about a really important topic that really depends also on the country that you live in, and there are differences there. So I know, for example, from colleagues in the US that it often goes via the cardiologist itself, that the cardiologist knows where there are private clinics. Even there are differences in states, and differences are there in how PGT is organized, but also, for example, if it's covered in insurance, and also insurance and coverage of PGT also differs among a lot of countries. And this is something that we are currently trying to make an overview of, as you know, and we are going to include that also in the consensus statement, I said. So hopefully next year we can publish a really nice overview of PGT differences among countries in Europe.
And how would you approach the situation if the GP or your cardiologist says, well, I don't think that's something for you? Or do you have the right, are you entitled to actually go to the clinical geneticist without the approval? Is that because you have a strong conviction that you actually want it, and the GP is not cooperating in that sense?
Shall I address that point? I think a very good question, a difficult one as well. In most clinics, the clinic will decide whether there's a reason to offer PGT or not. So not the doctor who is treating you, but the actual clinic offering PGT, because they will compare your question to other questions for PGT. So there are certain rules to offer PGT or to reject PGT. And they will compare, for instance, severity of your disorder and also the genetic test result to see whether they can and are allowed to offer PGT. So I would advise you, especially if there's a private clinic available to just contact them to see whether PGT is an option.
Okay, thank you. I have a question for our technical expert, Stefan. Will the recording be shared and the questionnaire? Where can we find the questionnaire? How can we reach all the people that are now live on the stream, but also the people that would like to fill in this questionnaire, because that would be a great help for Dr. Vase to get a lot of feedback on the questionnaire.
Yeah, absolutely. We will share it afterwards with the people that signed up for this webinar and couldn't join the live webinar, but we will also share it on the website, and we will send it out on the newsletter. So it's possible to watch it back on the website and on our YouTube channel, LMNA Cardiac YouTube channel as well. And same with the questionnaire. We will share the questionnaire afterwards as well. It will be most likely in a couple of days, but it's something that we have to organize.
So if you received the link of this webinar via family or whatever, and you're not subscribed to lmnacardiac.org, please do subscribe, and then you will automatically find it in the newsletter as well. Thank you, Stefan. Of the first question, and is it possible and available in all countries? That was, I think, partly covered by Dr. Donschot's answer as well, also in the US, but perhaps you know of the situation in other countries as well?
Yeah, it is available in most countries, but there are differences also in availability. For example, in the Dutch situation, there is only one center that does it, but there are multiple centers that do the intakes. For other countries, it's definitely organized. So it's always good to talk with a clinician, with your cardiologist, or with the person that you are in contact with to see how it is organized in your specific country.
Perfect. Thank you. So Audrey has a question. Good to see you here, Audrey. I have the Titin gene and plan of doing IVF in 2026. Do you have or know of resources to assist with genetic testing embryo before transfer? And she's located in California.
Yeah, I think Dr. Heijligers can maybe assist me in answering this question, but in the US it is possible. As I know, it's mostly through private clinics, so it's not immediately via in a medical situation. When you are already going for IVF, that's already, of course, half the procedure of PGT. But I think it's always very important to have some help in counseling and making the right decision there. Especially, we now talk mostly about PGT for a specific variant like LMNA or Titin, but there are also many other methods of PGT on the market. And yeah, that's not for everyone the right solution. So it's really good to get some help in making the right decision before going into this procedure. And in the end, maybe get disappointed, or it will take very long, and maybe in the end it wasn't even the right choice for the specific couple. So I do recommend always to talk with someone that has expertise in this field to see whether it's the right decision for a couple.
Perfect. I hope, does Dr. Heijligers want to add something to that, or you think this is covered?
Yeah, well, maybe shortly to add is that the question mentioned that you are going to start IVF treatment in 2026. It is also good to check beforehand whether it's a clinic that offers only IVF or whether the clinic actually offers PGT treatment, because if you have IVF in one clinic, it doesn't mean that the embryos are suitable for PGT in another clinic. So there are certain other very differences between the IVF clinics. So it's very important to check it before you actually start with the IVF treatment, since it's costs a lot, and you might have to pay part of the treatment yourself as well.
It's a very valuable addition. Thank you for that. Next question that I think we know this person. Our family has several daughters in their early 20s. The father has an LMNA variant. variants of unknown significance, are they eligible for PGT? And I think this covers questions of many patients, how to deal with variants of unknown significance for patients or mutation carriers that actually would like to start with this trajectory.
Yeah, unfortunately, up until now, the European Society advises not to start with PGT for variants of unknown significance, since we, of course, want to offer PGT for genetic disorders with a true genetic mutation or genetic diagnosis. And if we decide to offer PGT for variants of unknown significance, we are not sure that we are going to lower the risk Dr. Rodonschot told you about. So at the moment, in Europe, it probably won't be possible. I'm not sure whether they would do it in the US. I don't think so, but I'm not definitely sure.
And a question perhaps to Dr. Rodonschot there. If there is a variant of unknown significance, but the family is quite sure because of the family history, like parents, grandparents, other family members that even died due to a LMNA mutation because of cardiac arrhythmias or a dilated cardiomyopathy, how can people get their variants of unknown significance classified? What is needed to classify these VUSs into a classification that they are or are not eligible for PGT?
Yeah, this is a very complicated and frustrating point in cardiogenetics, which is not uncommon indeed. Variants of unknown significance are very difficult for the patients, for the family, but also for doctors. It's, as the name already says, it gives a lot of uncertainty. The way variants are classified is most often through just a checklist, like a scoring list. And in the end, if you score a variant on specific items, in the end, you have a score, and that determines if it's pathogenic, benign, or if it's in between. It is scored, for example, on segregation in the family, so how many patients have the phenotype with the variant, but only on that is usually not enough to classify a patient toward pathogenicity. Functional studies in the lab, of course, you know everything about it, that if you have that specific variant in cell models and you show that it reduces contractility, that really shows that that specific variant has an impact on cardiac function, that can also help in reclassifying the variant. So these are some of the most common manners to reclassify a variant. If a variant is very, very rare, that makes it very difficult, because then you usually only have a few patients with that specific mutation. And the less patients you have with a specific mutation, the less evidence you have. And that is really difficult to bump up that classifications toward pathogenic. And it's usually very important to just look at the evidence there is. And see whether there are some parts of the puzzle that can still be filled. But sometimes the very frustrating conclusion is, at this point in time, we can't do anything more. We just have to hope that in time there will be more information on this variant. But that's usually, not everyone has the time to wait for that, especially if you want to make decisions now and make these major life decisions. So that's very difficult.
Do you know, thank you for this clear answer. And do you know if so we always check on ClinVar, which is of course a website that tells us which specific variant is classified. And because we also have to look it up, right? Because we don't know all the many thousands of variants out of the top of our head. So that's so what happens if a variant got classified as a likely pathogenic or a pathogenic, and then it got reversed just by one opinion? Because I know of a certain variant, you know that as well, the 331 was a LP, likely pathogenic, class 4. And last year, at the beginning of the year, while it was always classified as class 4, in the beginning of this calendar year, it was somebody put variants of unknown significance in place. So how do you, in the clinical genetic field, how do you deal with that?
Yeah, that's a very interesting and actual topic that also is a little bit further on the presentation I gave, because the 331 variant is a very common variant, also well known. And we already knew before that it is a variant that is different than most LMNA variants, that the phenotype of the 331 variant is usually milder than other variants of LMNA. I still think it's a likely pathogenic variant because there are so many patients with this variant. There is a clear association with the phenotype. But I do think that it is a variant with a lower expression of disease. So if you remember the black bars I showed, if a normal LMNA mutation has a black bar like this, the 331 is probably a little bit less. So it's still a likely pathogenic variant, but with less disease risk associated with it. And this is a new way of thinking that we're just starting. And I think the classification system that we use is not very usable for these kind of variants. But I think the next coming years will help us in dealing with this difficulty.
Thank you very much. I have a question myself, actually, because I'm a little bit involved in gene therapy myself for the preclinical part. And with the gene therapy for not only LMNA, but other genes that are involved in cardiomyopathy, there's a lot of research going on for gene therapy. If somebody would get a gene therapy, a cardiac gene therapy, is it already known how the clinical genetics field is going to handle that situation? So locally, you are, for example, there is a correction, a DNA correction. Would PGT then still be eligible or applicable?
Good question. We are indeed thinking about what to do with our decisions when disorders become treatable. And yes, in the future, we might redecide on some indications to be less sure about offering PGT, but in the end, I think it's also based on the couple's wish and a question like, what is the risk of offering gene therapy? What are the side effects of gene therapy, and how do they weigh when you compare them to the PGT treatment, in which the woman is undergoing the PGT treatment comparing to the child is undergoing the gene therapy? And such question, you are going to compare what the severity and all the additional effects, and then decide for how long we can keep on offering PGT for a certain indication.
Mm-hmm. Yep. Thank you. I actually have a question for you. Now you're unmuted. Now you're muted again. But if you would unmute yourself again, perhaps you can answer my question. How difficult is the puncture, the biopsy of the oocytes, or how difficult is that, and how does that go wrong often? Is there a lot of anxiety around that topic? How do you deal with these patients on the spot?
Well, I'm not the one doing the punctions myself as a geneticist, but of course I do speak to the women who have undergo the IVF treatment, and it depends. There are quite some women who are anxious about the punction, so we give them pain medication, and even when they have severe anxiety for needles or for the punction, we can offer anesthesia in order to keep them calm and undergo the treatment, because the wish to have a child without a genetic diagnosis is so big that we do want to offer them special care in order to undergo the IVF treatment. The risk with IVF treatment is mostly, the side effect of the IVF treatment is mostly due to the hormones. So the women who need to inject the hormones have high doses of hormones, quite higher than in pregnancy and in a menstruation cycle. So what we expect is like psychological effects of the hormones, but also physical effects. When we start letting the eggs grow, we check with the ultrasound how many eggs are growing, but in some cases you can have too many eggs, and that will lead to severe physical complaints. So that's why we have to check like every 2 days with an ultrasound to see how fast the eggs are growing.
Okay, thank you. I have a question for Dr. Vase as well. External factors, diet or obesity or smoking or whatever external factor you can think of. How much does that affect PGT? If you smoke, are you eligible for PGT?
I'm not really sure, but I do think that when you're a smoker, you are eligible for PGT. I've seen some IVF rounds and also specifically PGT rounds, and it's not something that definitely isn't allowed. We do not advise on it either, because definitely it might have some effects. But I'm not sure if we already know what kind of effect different risk factors have on a PGT process right now.
All right. Small question also for Dr. Verdonschot about the intermediate variants, because there it got a technical, very interesting part. How do you know if the contribution of the intermediate variants, if that will reach a threshold? So you have your prediction models to see if you get to the threshold, but how do you know when you're at your job investigating if something reach a threshold, because you're actually looking at something which is not there yet, might not be there yet. So how do you know what if it reaches the threshold?
Yeah, we don't know yet at the moment. But now really in the moment that we're unraveling and seeing that not every variant has the same risk. So that's already a major change in how we used to think. So we used to think that every LMNA mutation is bad. Every LMNA mutation will lead to a very severe disease. But now, as you all mentioned, the 331, we see there are differences in that. And we are at the moment working on trying to put a number on it and trying to develop how we can counsel that to patients, what their actual risk is. Because when we get that knowledge, that will also help us way better for family members to tell what the disease is and to distinguish high-risk family members from lower-risk family members. And then that way also maybe we can prevent anxiety, because maybe it's not, the variant will never lead to disease, or prevent that someone every year has to go to the cardiologist. So I do have hope that we are getting there in the upcoming years.
Perfect. Thank you, Dr. Verdonschot. I think we are 55 seconds before the closure of this webinar. So first of all, I would like to thank the patients and the family of the patients that joined to this webinar this evening. I want to thank the three experts, Dr. Heijligers, Dr. Vase, and Dr. Verdonschot, for their clear explanation and different angles that you provided on PGT. It's very insightful and very much needed by the community. If there are any questions left, I see, one pops in just in time. So interesting. Thank you for the that's not a question, but it's very nice. It's glad to hear that you enjoyed it. If there are any questions, please send them over to LMNA Cardiac, and we can always transfer these to our specialist in this topic, and they are most likely very willing to help out also after this webinar.
This is something we can work on as well, Rogier. On the website, we have a medical provider list.
Mm-hmm.
So maybe there is a possibility for us to work on a site list or something where this is possible as well in the different countries. But maybe that's like, something where we need inputs. So maybe something for the future. Yeah,
we can actively participate in that as well. Yeah. Another reminder, please fill in the questionnaire of Dr. Vase. It would really be appreciated. And I want to thank you for this, for the attendance this evening. And you can watch this webinar in the stream that Stefan will provide you with a link so you can watch back. And thank you very much and have a great rest of the evening. Thank you.
Thank you.